Consortium. I welcome you all, and let's start.
Okay. Good evening to all of you. Sir, I am presenting a case of Mr. SS. Am I audible, sir?
Yes, sir.
Can you hear me, sir? Hello. Sir, am I audible?
Sir, your mic is muted, sir.
So shall I start?
Dr. Umesh, sir, your mic is muted.
Please start.
Okay, thank you. Sir, I am presenting the case of Mr. SS, a 47-year male, resident of New Delhi. He is himself the informant along with his parents, and history is reliable. He was admitted to the hospital on the 12th of February 2022 and examined on the 16th of February. Chief complaints are passage of blood in urine for 2 days before presentation. Coming to the history of present illness, the history of my patient starts in August 1988, when as a 14-year-old child, he developed fever, which was high grade, documented to be around 102 degree Fahrenheit. It was relieved by medicines and sponging. It was not associated with any chills or rigors and was continuous in nature. 1 day later, after fever, he developed a rash, which was developed over arms, legs, and chest and abdomen. There were multiple small red to pink colored spots of varying sizes, all being smaller than a button. These rashes, they were not associated with any pain, itching, any discharge or bleeding. He was reviewed for the above mentioned complaints and prescribed some antibiotics. However, 10 days later, he developed passage of reddish brown urine, which was spontaneous, painless, and the discoloration was present throughout the urinary stream. There was no history of any swelling over face or feet, no history of any fall in urine output or any burning micturition. There was no history of any joint pain, pain abdomen, loose stools, or passage of blood in stools. No history of any cough, breathlessness, hemoptysis, or chest pain. There was no history of any sore throat, oral ulcers, any pain or redness in the eyes, any nasal discharge, or any pain or abnormal sensation in arms and legs. He was admitted for the above mentioned complaints and evaluated. He was told to be passing blood along with protein in his urine, but remembers being told that he had a normal blood pressure and normal serum creatinine at presentation. Okay. He was treated initially with antibiotics, intravenous, and other medications, and was advised injectable penicillin once a month. The fever, rash, and hematuria, it resolved in a week after treatment, and he was discharged. However, 3 weeks later, he again had a second episode of fever with rash along with hematuria. This time on evaluation, he remembers that his creatinine was found to be around 4 milligram per deciliter, and again he was told to have hematuria and proteinuria. Again, he had normal blood pressure and normal urine output. For these complaints, the patient underwent a kidney biopsy, wherein he was told that nearly 80% of his kidneys were involved, and he would require some drugs, immunosuppressive drugs for treatment. He remembers being treated with steroids, initially high dose through injections, followed by oral drugs, and an oral tablet, cyclophosphamide, which he took for 3 months. With this treatment, there was a resolution of his hematuria and improvement on serum creatinine over a period of 2 months, and there was no further recurrence of hematuria. The steroid, he remembers, was tapered off over a period of 6 months. He remembers that subsequently his serum creatinine after discontinuation of therapy was in the high normal range, in the range of 1.2 to 1.3 milligram per deciliter. He maintained on a regular follow-up since, and over the years, he remembers developing a progressive rise in serum creatinine, which over the initial first 4 to 5 years was in the range of 1.5, 1.6, but steadily started increasing along with development of blood pressure around 5 years after the first onset of disease. His blood pressure, initially he required a single drug, but it progressively increased to 2, 3, and finally 4 drugs by 2009, along with a rise in creatinine to 7 milligram per deciliter by 2009, that is 20 years. Because of this steep rise in serum creatinine by 2009, he started taking some Ayurvedic medicines for treatment of kidney disease. This was followed by a rapid rise in serum creatinine to 13 milligram per deciliter, along with complaints of recurrent vomitings and decreased appetite. For these problems, he was again admitted to a hospital and initiated on hemodialysis. Initially, he remembers through a left femoral catheter and then through a right neck line. Left brachiocephalic AV fistula was created, but this failed and did not function. He was subsequently told about the poor quality of veins, and a tunneled catheter was inserted in the right side of his neck. He was initiated on twice weekly dialysis, and during this time, he became anuric over a period of 6 months. However, he started having problems with blood flow in the catheter and was counseled about multiple vascular access failures and advised to switch to peritoneal dialysis. Peritoneal dialysis catheter was inserted, and within 2 weeks, he remembers being shifted to peritoneal dialysis. He remembers developing one episode of peritonitis within the first 6 months of initiation of therapy. This episode was treated with intraperitoneal antibiotics and got resolved. He has been on CAPD since, provider being himself and assisted by father and sometimes by a PD technician. He uses 2-day dwells of 1.5% dextrose and 1 overnight dwell of 7.5% icodextrin. His creatinine usually ranges from 10 to 12 milligram per deciliter, and daily CAPD output is in range of around 1 liter. There is no history of any breathlessness, orthopnea, or any swelling over body. No history of any anorexia, nausea, vomiting, body aches, or bony pains. His usual hemoglobin ranges between 9 to 10 milligram per deciliter, and he does not have hasn't had any further episodes of abdominal pain. Also, no pain with inflow or outflow. He has a normal blood sugars. He usually changes his transfer sets within 6 months. However, his BP tends to remain on the higher side despite poor medicines. He was registered.
Abhishek,
Sir.
just tell us how many completed years of CAPD now? I mean, when was it initiated?
So it was initiated in 2011, and now 11 years he has completed. Nearly 11 years.
Yeah, go on. Yeah, okay.
So he was registered for cadaveric donation in 2010 and has had multiple unsuccessful attempts at transplantation, with reasons ranging from withdrawal of consent by the cadaveric family to a positive cross match to presence of infection in the donor kidneys. In June 2019, he developed sudden onset hematuria, that is a passage of frank red blood in urine, and this was associated with flank pain, left-sided flank pain. He was evaluated for the same and told to have very high blood pressure. He remembers a systolic reading to be 190, and was told that he has multiple cysts in both kidneys, and there had been a rupture and bleeding in the one of the cysts in left kidney. He
I thought he was anuric.
Yes, sir. He had anuric, but he had one episode of this hematuria with flank pain.
Okay, well, passage of
blood
per urethra, you mean? No?
Okay.
Because
yes.
anuria happened quite some time
yes,
ago.
Yes, sir. He has been anuric for 10.
Yeah. So blood per urethra,
Sir.
right? Okay, right.
So
Okay.
he had passage of frank blood in urine associated with left flank pain with high blood pressure, was told to have multiple cysts and underwent left open nephrectomy for rupture in his cysts. During this admission, he was switched to hemodialysis and received 3 sessions of HD through a femoral catheter perioperatively and had received 1 unit of blood transfusion. He was told that there were no cancerous changes on biopsy evaluation of the kidney. Now, 2 days prior to admission, he again developed passage of frank blood in urine. This was again associated with the very high blood pressure, with the blood pressure reading being 200 by 120 millimeters of mercury. Again, on evaluation, was told that this time he has had a cyst rupture in his right kidney and was admitted for the above-mentioned complaints and underwent a right open nephrectomy on the 12th of February itself. During the hospital stay, he has again had 2 sessions of hemodialysis through a right femoral catheter and 1 unit of packed red cell transfusion. As on post-op day 4, he is asymptomatic. His bladder irrigation discontinued 1 day back, and Foley's catheter and femoral have been removed. He has been allowed soft diet, ambulating, and has been planned for restarting his peritoneal dialysis. He says that his BP medicines have reduced in the post-op period.
Right.
So the past history, so there is no history of diabetes, heart disease, any CVA, seizures, COX, or any other chronic illness. A personal history, he's a graduate in computer science and has worked in an MNC for around 10 years, which he discontinued once he developed end-stage kidney disease. And now he helps his father's business. He is unmarried, non-vegetarian with normal appetite, bowel, and sleep. He has no addictions. So family history, he's a first order child through a non-consanguineous marriage and has a younger sister. There is no history of similar illness in the family. There's no history of any allergies. So his current medications include blood pressure medications of amlodipine, clonidine, metoprolol, and prazosin, along with weekly injections of darbepoetin with iron, calcium, folate, and vitamin B tablets. So this is my history.
Yeah. So, inviting any comments or questions that you may want to ask the presenter, any clarifications? Anybody wishes to know anything specific from him? I think he has given us a very, very comprehensive history of his current illness, right from the initial fever and rash to date after the second nephrectomy. So, and all the negative histories are also carefully noted by me. So, if there are no questions, we'll invite him to give a provisional diagnosis. Dr. Bansal?
Yes, Abhishek,
Sir.
starting with your history, can you summarize in few lines?
Sir, my patient is a 47-year male who has a history of 2 episodes of exanthematous fever associated with hematuria and azotemia at 14 years of age, with kidney biopsy revealing 80% damage during the illness, with remission of the disease to steroids and cyclophosphamide, followed by a progressive decline in renal function and worsening of blood pressure over a
So
period of.
let us first discuss this part of the history,
Sir.
which is a 14-year-old child presenting with a febrile illness and hematuria.
Yes.
So what is your takeaway from that? What is your differential diagnosis of that?
Yes.
Sir, in this age group, with the presentation of fever and rash, sir, there is a first possibility would be that of post-infectious or post-streptococcal glomerulonephritis. Sir, however, this patient, he had recurrence of this disease along with rapid deterioration of renal function.
Why do you say rapid deterioration?
Sir, because in a period of 1 month, when first evaluated, when he had a normal creatinine, but in a period of 1 month, when he had the second episode, his serum creatinine had increased to 4.
No, we should be talking in terms. We should be talking in terms of he had an acute nephritic illness with a rash, okay,
Yes.
a febrile illness. Na?
Yes.
Acute nephritic illness, the DDs would be a post-infectious.
Yes.
But why do you say, I mean, a 14-year-old child, do you think they are normally given steroids and cyclophosphamide for
No, sir. No, sir.
post-infectious? So what I'm trying to say is,
Yes.
it is nice to go by syndromic diagnosis of his illness, acute nephritic illness,
Yes.
where even a rise in creatinine is absolutely par for the course.
Sir.
Hematuria is par for the course. There was a rash, there was
Yes.
fever preceding.
Yes.
So either it could be a post-infectious glomerulonephritis or
Sir, it could be a systemic vasculitis like Hinox-Schönlein, because he had rash.
yeah, he's that age, 14
sir.
years of age, and he's got rash.
Yes, sir.
Extensive rash, which you mentioned, you mentioned
Yes.
the area of distribution.
Yes, sir.
So that, anything else?
Sir, in this age group, again, sir, the patient could have complement-mediated diseases like, sir, C3 glomerulonephritis or dense deposit disease presenting with rapid.
How often are rashes seen in dense deposit disease or a C3 nephritis?
Sir.
How common are they?
Rash is, sir, less likely, but
Yeah, I mean, we try to fit in everything. Na? So post-infectious, you can have rash.
yes, sir.
Okay.
Yes, sir.
Yeah. Hinox-Schönlein purpura, you can have extensive
Yes.
rash. Absolutely. A systemic vasculitis of
Vascular.
another kind can give you rash.
Yes, sir.
I mean, it can.
Yes.
Okay. Preceded by fever and rash. Anything else?
Sir. So my
What about
differentials
SLE?
were systemic
Can it be
vasculitis.
SLE in childhood?
Yes, sir, there is a possibility, although
Have you
less
seen
like
patients of SLE in children?
the name.
You haven't seen?
No, sir. Not in this age.
So what is peculiar to SLE in children?
Yes. A lovely question.
Sir, I don't know.
Childhood SLE, what is the peculiarity?
Sir, I don't know.
Neurological involvement is more?
Okay.
Okay.
Sir.
So actually, you should be with an open mind. There is a nephritis, nephritic
Yes.
illness, as Sir has said.
Yes.
So nephritic illness, you can immediately think about it. Anti-GBM disease, quasi-immune nephritis,
Yes.
immune deposits. Immune would be low C3 or normal C3, and this would be either SLE or infection as PIGN, IgA nephropathy, like that. You keep it in your mind.
Sir.
Now you see this age group, you won't expect an ANCA vasculitis in this age group.
Yes, sir.
IG, the anti-GBM can have a bimodal distribution, can have in second, third decade and later on in life.
Yes.
And then immune deposit diseases. So this is how you should analyze, and especially this patient has a rash.
Yes.
So now we have already enumerated the possible causes. Now, how will you narrow down? Then what happened? Now he had 2 episodes.
Yes, sir.
So another interesting question comes is that he was treated with cyclophosphamide and steroid
Yes, sir.
after biopsy.
Yes, sir.
So what could be the reason for that?
Sir, he remembers being told that 80% of glomeruli were involved. Likelihood, sir, that these were crescents that he had on his biopsy. And so crescentic glomerulonephritis was treated with cyclophosphamide and steroids.
So you feel that like it was at age of 14 and now he's 40, like he
47.
reached ESRD at 37 or something.
Yes, sir,
Is it?
around 35 years.
So that means he was very well managed and he responded very well with the
Yes, sir,
steroid and cyclophosphamide.
He remembers being totally disease-free at discontinuation of treatment with creatinine in the range of 1.2 or 1.3.
No, for how long? For how long was he?
This was, sir, he remembers his creatinine started rising around 4 to 5 years after this disease presentation.
Exactly. And he is on dialysis from 2011.
11, yes, sir.
Right. So
Yes, sir.
that means from the age of about 27, 28, he is on, no, 26, 27, he is on dialysis. 4 to 5 years before that, he enjoyed a blissful life. That is when he was working for an MNC as a
Sir,
thing. Huh?
So total duration of, he started, developed ESRD around 20 years after this episode. So in 1988, he had this episode of acute nephrotic illness, and by 2009, he was started on dialysis. So 20 years he had. It took him.
Ajay, he received immunosuppression only for 3 months.
Yeah, sir, cyclophosphamide, he remembers taking endoxin tablet for 3 months during that time, 50 mg.
So what you can infer from that regarding the possible causes? Like he was not given any maintenance therapy. He was just, the medicine was stopped.
Yes, sir. So usually, sir, self-limiting illnesses that do not tend to recur, they would be treated with a very small
probability बताइए.
Sir, so with this, sir, again, probability would be one that he has post-infectious glomerulonephritis with recents, or sir, inoxon and IgA vasculitis with recents, because they are both
the behavior. Yes, the behavior, total 6 months of immunosuppression, 3 months of cyclophosphamide, 3 months full dose steroids followed by tail off.
Yes.
Goes into remission, stays in remission for 4 to 5 years.
Yes, sir.
What would be the probability? And he was told he had a fairly good amount of proteinuria at the onset. You told us, you made that statement.
Yes, sir.
Anna? So, yes. And with the rash, the age of onset, 14 years of age, and you know, so why don't you consider IgA? What is the natural history of IgA?
Sir, again, sir, in IgA nephropathy, sir, 30% patients, they present usually in the second to third decade of life. They present with either hematuria or hematuria with proteinuria. 10% of the patients, less than 5% of patients present with presentic glomerulonephritis, and 10% may present with nephrotic syndrome. Sir, again, these patients have progressed to ESRD. Usually 30% patients progress to ESRD by 20 years of age. By 20 years of illness duration.
So it is 30 to 50% may progress to ESRD.
Yes.
Okay, all right. So as against what Dr. Ravi asked you very categorically, he was given 6 months of immunosuppression, then nothing, no maintenance phase, nothing. So, I mean, we presume that the treating nephrologist was a wise one. So, what all does it rule out? No maintenance immunosuppression.
Sir, lupus.
Keep in mind at the background the age, okay?
Yes, sir.
The presentation also.
Yes, sir. Among our differentials, sir, it rules out lupus nephritis, ANCA vasculitis.
Yeah. And is not the behavior of a childhood post-infectious glomerulonephritis. Standard behavior. It is not, because something like better than 95% of them stay remitted. Childhood post-infectious glomerulonephritis. Vis-a-vis the adults, right?
Yes.
Okay. Then it rules out SLE.
Yes, sir. It rules out SLE.
Because you've given us a host of negative histories, no joint pain, no this, no that, and all that. It rules out SLE. Right?
Yes.
So, systemic vasculitis, SLE, post-infectious glomerulonephritis, not the behavior at all. Yes. So, again, you will come back to
inoxon.
The residua, that is IgA nephropathy, which is well known in its natural history to progress, isn't it?
Yes.
So another question is that, like, if a patient has a PIGN, then what are the long-term complications of PIGN?
Certain patients with PIGN, majority, they have proteinuria. Usually, majority tend to have proteinuria. They don't have azotemia, because it is a self-limiting illness, tends to resolve. However,
no, you have to see, like, at 1 year follow-up, at 20-year follow-up. What is your expectation? Like, if a patient is having resolution of PIGN, do you expect the proteinuria to be present at 1 year?
Sir, patients usually tend to have proteinuria at 1 year. So majority tend to have proteinuria at 1 year, sir.
I think proteinuria resolves faster. RBC may persist for a year,
Yes, sir.
but in a long-term follow-up of these patients, they can develop hypertension,
Hypertension
persistent proteinuria,
and yes, sir.
progressive kidney disease, and this may be to the tune of 10% at 20 years.
Yes, sir.
So long-term complications of PIGN are known and they can progress to chronic renal failure, like in your patient. But as you said that there was a lot of proteinuria in this patient initially. So PIGN generally don't have so much of proteinuria. Very less percentage of patient will have proteinuria. Okay, so now we have a patient with a nephritis and he had progressed to ESRD. And then he was on dialysis and there was multiple vascular access failure.
Yes.
So what do you infer from that multiple vascular access failure?
Sir,
What could be the causes for that?
sir, again, sir, in patients with systemic vasculitis with poor arteries, inflammation, sir, they could be cause of the vascular access failure. Also, sir, patients who tend to undergo repeated central line catheterizations, they tend to have poor central veins. And
So did this patient have a lot of central lines before
No,
he
sir.
actually had a fistula made?
no, sir, this was on the first presentation of ESKD itself. He had a fistula in the left brachiocephalic fistula actually, because he had poor veins in the.
So is there any episodes of thrombosis, vascular, venous or arterial thrombosis
No, sir.
in
No.
any part? Is there any history of CVA?
No, sir.
And
No
you have
history.
to
of-
rule out
Yes, sir.
all the virtue triad, like the vascular factors,
Yes.
hypercoagulable factors,
Yes.
and flow of the blood.
Yes.
So these are the
Stays.
parameters. So were the vessels very thin or he had a long-standing illness? Because of that, I'm not sure from your history any like what could be the cause of multiple
He
access
had
failure.
not had any other systemic involvement in terms of vasculitis, either
But
CNS or.
was he investigated for causes of multiple access failure for hypercoagulable states? Did he tell you that, or was he on any time of any
No,
sort
sir.
of anticoagulation for that?
He did not receive any anticoagulation for the same, but definitely, sir, he was not evaluated for poor vessels.
Sir, Dr. Mishra?
No, fine. I took a break, So, how common is hypertension in such cases, which turns to for drug and poor control?
Sir, usually, sir, once renal parenchymal disease sets in, so
Right. Yeah.
so patient's
So-
renal parenchymal disease is a cause of resistant hypertension, sir, and progressive decline in renal function. He says that his antihypertensive requirements actually increased over time.
Absolutely right. Initially there was this belief that IgA nephropathy usually not accompanied by hypertension, but that myth has been busted. You can have malignant hypertension also in a condition like IgA nephropathy. In any case, by the time ESRD ensues, the blood pressure may elevate to any extent. Absolutely right. Okay. So that question, he was not investigated for
No, sir,
hypercoagulable states.
he does not remember being investigated, neither does he have history of any other involvement of any other system in terms of.
No, did we ask him?
Sir, I asked only whether there were any history of strokes or any peripheral vascular diseases, any claudications, but per se, he was not investigated for.
No, it's a very important point brought up by Dr. Ravi, because in the sense, he is a young man, relatively young man.
Yes.
Historically, you've given us nothing. And yet he had repeated vascular failures, vascular access failures. So it is worthwhile, this is to all students, it is worthwhile investigating him for, hypercoagulable states and, loss of vascular access repeatedly. That also becomes important, in order to preserve the patient. So this was probably not done because a lot of us in clinical practice tend to say, oh yeah, nahi bana hoga fistula. That is not correct. It is worth investigating the patient for this. Anyway, so the decision to switch to CAPD was a good one. What do you say?
Yes, sir.
It has proved itself, no?
Yes, sir.
11 years on dialysis, and he's been fine on PD, and he's meticulous with his discipline. You repeatedly stressed that there was no recurrence of pain, abdomen, peritonitis, cloudy fluid, all that, isn't it?
Yes, sir.
And he does it all himself, which is
Yes.
also a very, very important aspect, isn't it?
Yes.
Yeah. Okay. So
So let's come to the present episode now. The present episode where he came to the hospital, he was on PD. You said he presented with left side abdominal pain.
Yes, sir. This is, sir, back in 2019, where he had flank
Yeah.
pain, left flank pain, and passage of blood in urine.
So what could be the differential diagnosis for this? You know, always whenever you have presenting some positive findings, try to analyze in a way that what could be the possibilities,
Yes.
jot them down and try to rule out like which all you can rule out. So that is how you should approach in a, clinical discussion. And that is what is important actually. Reaching to diagnosis is separate,
Yes.
but discussing the possibilities and how you would narrow down, that gains you marks.
Sir,
So what could be the differential in that?
Sir, gross hematuria in this patient, sir, can have sir, urological causes, and sir, also, sir, the fact that he was evaluated.
बता दो ना 1,
Sir.
2, 3, 4 causes बताओ.
Sir, patient can have sir, nephrolithiasis. Patient can have.
आपके पास एक डायलिसिस पेशेंट
Yes.
है जो जिसको हिमेचुरिया हो गया और पेट दर्द हुआ,
Yes, sir.
है ना? तो क्या आप सोचोगे हिमेचुरिया का सबसे कॉमन कॉज क्या है?
Nephrolithiasis.
हाँ,
सबसे कॉमन कॉज
स्टोन्स हैं और
Stones.
और क्या है?
Sir, UTIs.
upper UTI,
UTI.
pyelonephritis, because he got abdominal pain.
Yes.
Isn't
UTI
it?
and
UTI, stones, then what else?
sir, in patients on long-standing dialysis, they can have developed cystic kidney disease, and there can be a rupture in hemorrhage.
That is what you have actually, ना?
Yes,
वो तो
sir.
पता ही है, वो तो
Yes.
आगे उसी पे जाना है.
Also, sir,
What
sir,
else?
urological, so patient can have renal cell carcinoma or a urothelial carcinoma. They can also present with frank passage of frank blood in urine.
Nutcracker syndrome क्या होता है?
Sir, nutcracker syndrome is caused by compression of the left inner vein by the superior mesenteric artery. This causes, sir,
And artery and the
sir, aorta.
aorta. Yes.
So this causes renal artery, left renal,
Vein or artery?
left renal vein thrombosis, and
Yeah, exactly. So
compression and
renal vein
hemophilia.
thrombosis
Yes.
can
Yes.
happen.
yes,
Okay. What else? There can be a renal arterial thrombosis with infarction in the kidney also, which will also give
Yes.
you pain and
Yes.
frank hematuria. Yes or no?
yes, sir.
Well, remote, but that is another possibility.
Yes.
Then, though he is rather young, one more thing that you will have to talk about is malignancy.
Yes, sir. Both
You know?
renal and urothelial malignancy.
Yeah. Which is commoner? I mean, hematuria is commoner in renal cell carcinoma or urothelial tumors?
Sir, urothelial tumors.
Yes.
More.
Comparatively, I mean, if you take percentage wise, urothelial tumors, especially of the upper urinary tract, can give you frank hematuria more often than renal cell carcinoma. Okay.
Did your patient have risk factors for malignancy?
Very
Sir,
nice.
The fact that, sir, he has been on dialysis. I mean, patients of end-stage kidney disease on dialysis, they tend to be at a higher risk of developing malignancies as compared to general population. Other than this, sir, sir, there is no history of any smoking or any other environmental exposures.
What are risk factor for malignancy? RCC.
Yeah.
Sir, family history, same. Then, sir, patients who have cystic kidney disease,
Which cystic kidney disease? All cystic
Ah,
kidney disease?
yes.
Sir,
You
sir,
said smoking,
yes,
agreed,
sir.
admitted. You
Sir,
said family history, agreed.
sir,
Then
so
which cystic disease can
it-
give you the malignancy?
sir, autosomal dominant polycystic kidney disease also increases risk of malignancy. Acquired cystic kidney
Correct.
disease,
Acquired cystic disease, acquired cysts of the kidneys
sir.
seldom go malignant. You know, the percentage is
very-
rather low. It's not that it can't happen,
Yes, sir.
but
Sir,
that
it is
percentage is lower.
higher as
84.
compared to general population. Then,
Yeah.
sir, patients may have exposure to, sir, recurrent infections, bladder infections, urothelial malignancies, transitional cell carcinomas.
One more organ that can give you frank hematuria in the urinary tract only, though he is rather young.
Sir,
Prostatic
Pros-
malignancies can also give you frank hematuria. Okay.
yes.
All right. So you told us that you asked him the question and he says no, he was told that he does not have any malignancy.
Yes.
He underwent a left nephrectomy
Yes.
in 2019.
90.
Now we are down to 2022,
Yes.
right?
Yes, sir.
And this time again he had similar symptoms.
Yes, sir.
And this time they decided to remove his right kidney.
Yes. Sir.
Yes.
Yes.
Once again, you know, you've not told us whether the resected specimen had any malignancy or not.
Sir, because he was evaluated prior to biopsy reports, I had examined him prior to the biopsy. His final biopsy reported not yet come.
Achha, not yet come. All right. Yeah, right. Not yet come. But otherwise, any B symptoms in him? B
Yes.
symptoms means fever, weight loss.
Sir, no anorexia, weight loss, no fevers or no symptoms of chronic.
Right. So he is bilaterally nephrectomized.
Yes, sir.
Can you tell us the consequences of a bilateral nephrectomy in a given patient? He is already ESRD, long standing. I mean, you know, more than 11 years. But however, even this has consequences. So what would be the consequences of a bilateral nephrectomy?
Sir, in total, sir, loss of renin release in him. No
And
production of renin.
anephric state, what
Yes.
all can it lead to?
Sir,
In other words, kidney has many other functions to subserve, endocrine and others, right?
yes, sir.
Fine, it may not be doing the filtering function that
Yes.
we already know is end stage renal disease as regards
Sure.
that creatinine stays around 11 on dialysis. But
Yes.
there are other consequences. What are those other consequences of
Sir.
anephric state?
Sir, there will be no synthesis of renin, sir. Also, sir, the interstitial functions like formation of vitamin D and erythropoietin, although he is ESKD, but even they will be absent in anephric kidneys.
What does kidney do in glucose metabolism?
Sir, it maintains it causes reabsorption of glucose and filtering and reabsorption of glucose in the
Filtration function was lost very early.
sir.
Is ESRD. Anything else that it does, kidney? What happens to the insulin, endogenous insulin in the body?
Sir, kidneys.
Are you
sir,
aware?
Sir, they excrete the insulin as well, sir. So
Unchanged insulin is excreted in
no,
the
sir.
urine.
So metabolism of the insulin.
Yeah, it's
occurs in the
broken
kidney.
down in this thing, in the kidney. Insulin,
Yes.
after its function is over, it is broken down. So
Yes.
that's another consequence, right?
Yes.
It may be more difficult to manage their renal anemia if you are totally anephric,
Yes.
right?
Yes.
That means the requirement of both. I mean, you know, erythropoietin hormone, as well as maintenance of hemoglobin, normal hemoglobin, would be jeopardized if you're totally anephric. Yes or no?
Yes, sir.
Vitamin D function got lost very early on. I mean, that is why 11 years on dialysis. So he won't be making any active vitamin D from his kidneys in any case. So that he will require exogenous administration.
So let me just complete that part when we were discussing the cystic kidney diseases, because you had done nephrectomy for both the kidneys and both had cystic kidney disease changes only.
Yes, sir.
So what are the cystic kidney diseases of the, what are the cystic diseases of the kidney?
Sir, cystic diseases can be classified as solid as well as masses can be classified as solid as well as cystic.
क्या बोल रहे हो यार,
sir.
मैं cystic disease की causes पूछ रहा हूँ kidney के.
Cystic disease की classification
Sir,
बता दो.
Causes बता दो.
सबसे
Sir,
पहले
cystic diseases
with
sir, based on the kidney size, and large kidney size can be autosomal dominant and autosomal recessive kidney
are
diseases.
autosomal recessive kidneys enlarged? And when does ARPKD hit you?
Sir, this is ARPKD usually, sir, either sir, perinatal period or so early childhood.
Yeah, first decade of life, and
Yes.
they seldom survive the second completed decade.
Yes, sir.
So ARPKD and rule out, put
Yes,
it aside. Then ADPKD, okay.
Yes, sir. Then,
Where
sir,
you
it
like,
can be
what else?
sir, autosomal dominant tubular interstitial kidney disease, sir, nephronesthesis, then, sir, kidney diseases associated with extrarenal manifestations, sir, like Bardet-Biedl syndrome, or sir, Joubert syndrome.
Von Hippel-Lindau सुना है?
Yes, sir. Those are, sir, Von Hippel-Lindau and tuberous sclerosis. Both can be associated with.
इन्हीं दोनों में ज्यादा malignancy का risk होता है.
Yes.
ADPKD या इन सब में बाकी medullary cystic disease, nephronophthisis, medullary sponge kidney,
Yes.
glomulocystic disease, इन सब में नहीं होता इतना. ठीक है, इनमें होता ही नहीं एक्चुअली. तो प्री मैलिग्नेंट कंडीशंस में मेनली तो यही है ना. और एक एक्वायर्ड सिस्टिक डिजीज होता है, आप जो कहना चाह रहे हो, आपने टॉपिक रखा है एक्वायर्ड सिस्टिक डिजीज क्या होता है? व्हेन हाउ डू यू डायग्नोज दैट?
Sir, acquired cystic kidney disease is usually seen in patients who are ESRD, long-term ESRD patients. Tends to occur.
You have to have ESRD to have acquired cystic disease. Could I have acquired cysts in the kidneys?
Yes, sir.
I'm 62.
Yes, simple cysts
But that's
tend to
also
occur
an acquired cystic
with age.
disease. Yeah, so first, सबसे पहले physiologically, with age alone, you can get cysts,
Yes.
Yes?
Yes.
After that comes the dialysis part,
Yes.
the end-stage renal disease. So what percentage of people of ESRD get cystic disease? It's in terms of the duration of
Sir,
your ESRD.
At initiation of ESRD, around 5% of patients tend to have acquired cystic kidney disease, which by 10 years of dialysis vintage, nearly 80 to 100% of patients develop acquired cystic.
A very broad way of saying is, in the first 2 years after initiation of dialysis or reaching ESRD,
Sir.
fully 6 to 21% will have cysts in the kidney. Between the duration of 2 years and 10 years, the number jumps up to 60% at different this thing, and about 10 years, more than 80%. More than 80% in the sense, if they didn't have 100%, then you can't say, no, you've not been on dialysis for more than 10 years. So that is why it is said more than 80%, right? So that is the time frame.
And what would be the incidence of malignancy in these?
Sir, less than 1% of patients have acquired cystic kidney disease.
नहीं यार, it is
No,
more.
it's not that low. No, I also disagree with that 1%.
Sir, actually, sir, it is seen mentioned
It
that
is
it's
up
less
to
than
10 to
1%, but
20
is seen.
10 to 20% of these patients can be harboring malignancy,
Yes,
and these are actually very indolent and slow growing malignancies.
correct.
Generally, they don't spread so fast,
Yes, sir.
but still they are malignant. They are malignancies.
And it could be multicentric, multiple
Yes, sir.
cysts could go
Multicentric
malignant.
and bilateral.
And these kidneys will be small.
Yes,
So
sir.
in your patient, were it small kidneys with cyst or was it an enlarged kidney with cyst?
Sir, he had, I mean, I have seen only this time, sir, it was small kidneys with cyst, 8 centimeters.
Do you have any record to say that, or did the patient tell you? How do you know it was small kidney or it was large kidney?
Sir, on the initiation of dialysis itself, sir, 11 years back, he has a history that he had bilateral small kidneys here.
Small kidney. Okay.
Oh, this time they must have worked him up now for his right kidney because he got.
Yes, sir. And this again, sir, this time again, sir, he underwent a
So
CT
that's
scan.
all. I mean, at least the basic diagnostic modalities must have been employed.
Yes, sir.
Including
So
an
he had a right
so
small
you can
kidney.
tell us about the size of the kidney during this present hospitalization.
This time, sir, it was sir 7.8 centimeters size of the kidney. Right?
And how many cysts were there in each kidney? One cyst, two cysts?
Sir, I don't know about the left kidney, sir. It was removed, but this had shown, sir, multiple cystic lesions in the
So
kidney.
generally, there should be at least three cysts
Three
in
or
the
more,
kidneys.
at least 3 or more.
And to say that, or it could be even simple cyst, you know, everybody will have cysts with age.
That thing also is more true for autosomal dominant polycystic kidney disease, that bilateral disease, more than 2 cysts per kidney, and these are essentially cortical cysts, right?
Cortical cysts.
Yeah. So this time also, the ultrasonologist, a good ultrasonologist who sounded the right kidney can tell you the number of cysts, number one,
Yes.
and whether they are cortical or corticomedullary.
Yes.
So, do you ever get corticomedullary cysts in acquired cystic disease of the kidney, ACKD?
Sir, usually these cysts are cortical cysts only.
Exactly, they are cortical because the filtration function and the tubular, this thing is already happened,
Yes, sir.
gone. So, these are essentially cortical cysts,
Cortical.
right?
Yes.
So what are the now management issues now? You have completed your case now, final diagnosis, and what are the management issues?
Sir, my final diagnosis, it is chronic kidney disease, stage 5, CAPD. Basic disease being chronic glomerulonephritis. Possible etiologies being hinox-Schönlein purpura, infection-related glomerulonephritis, and systemic vasculitis with acquired cystic kidney disease with cyst hemorrhage, status post bilateral nephrectomy, hypertension. These are findings. Secondary hypertension.
Instead of removing the right kidney, could we have attempted something else?
Yes, sir, embolization.
Theoretically, yeah. So, I mean to say, why I am again and again taking you back to this, it's not pleasant to be anephric.
Yes.
Yeah. So, if you can identify the culprit, the cyst which is bleeding,
Yes.
you could always embolize it, angioembolize the thing and knock out the bleeding, and still preserve that kidney.
Yes.
Unless, of course, there is evidence to suggest that there is cyst infection, which can be, of course, very dangerous. Because cyst infection can cause systemic sepsis, and systemic sepsis can threaten life. So, going further into the initial workup rather than rushing into a nephrectomy, right, would have been worthwhile.
Second
And
could be, sir, the reason of like if there is a possibility of malignancy, because these are patient is on long-standing dialysis. If there would have been doubt in the mind of the treating doctor that there could be malignancy, then also probably nephrectomy is a better step.
Yes.
No,
So,
agreed. I mean to say there are then good evidence, good imaging modalities available. After an ultrasound, you could always do a CT. After a CT, you could still define them better with MRI. You could still do a FDG PET. scan, and you can still try and, that's
Salvage.
why I asked questions about B symptoms and so on and so forth. He's been very well preserved, considering that he's been 11 years on CAPD. He's grown to 37 years of age. No, from 14 years when he began the illness. So what I'm trying to say is, all of us at times, take precipitate clinical decisions. It is nice to complete workup, of course, within the affordability of the patients, So it is not that you see this thing, cyst with hemorrhage within causing frank hematuria, or rather, I would like to call it passage of blood in per urethra, because urine to pata nahi kab ka band ho gaya. So I mean to say, we can work this up if you had an ideal situation. Many of these cysts which have ruptured and bled have been dealt with angioembolization with fair amount of success. That cysts develop is a given in ESRD. I just told you that beyond 10 years of dialysis, more than 80% kidneys will show cysts, and this time, of course, it's been again a dramatic and sudden event. So we did not get any evidence to suggest that there was a cyst infection. But even that becomes a precipitate cause for nephrectomy. Now, if you suspect there is any infection, and there are, of course, so many ways of trying to prove that there is an infection. There won't be a urine available for culture, but you can always do blood cultures. You can do procalcitonin. You can do C-reactive proteins, and so on and so forth. Leukocytosis, whether there is any or not. That would precipitate the doctor's decision for nephrectomy. Absolutely. I agree, because the idea is to save the patient and not a diseased kidney. But otherwise, there is merit in keeping, in not reducing the patient to an anephric state. So it's a good topic to read up the consequences of an anephric state.
So I think, sir, we can conclude then. Anything more to discuss?
Absolutely.
Any questions?
We ask the attending doctors if they have any clarification to seek. The other students who are listening to this case presentation, do you have any questions in mind? Remember one other thing, post-infectious glomerulonephritis. It is not that you can't have frank hematuria, but the description that you gave right at the beginning, along with that extensive rash and all that, childhood acute nephritic illness seldom has heavy hematuria which is frank. Microscopic hematuria is a more likely consequence, in those. Now, IgA can also have either microscopic hematuria or frank hematuria, but in post-infectious, the incidence of absolutely frank hematuria repeatedly, twice it happened, at his presentation. And both times he came down with rashes also. What was missing? Probably enoxaparin. I know you asked the question whether there was any pain abdomen, and he denied that there was any pain abdomen at that point in time. But that is another thing that is common with HSP, enoxaparin. And I'm willing to grant it to you that though a very assiduous attempt should have been made, Abhishek, to obtain the person's original biopsy report, because nobody throws a biopsy report away, believe me. They think it's a very precious document that a piece of their kidney was removed. So it would have been nice to look at his original biopsy. It would have cleared our minds, further, isn't it? So whatever documents you can lay your hands on, it's worth seeking them. Okay. Yeah. So I have finished with this thing.
So I would just like to say that it was well presented, but you should try to openly discuss all the differential possibilities. Like in hematuria in second decade, you can Alport's thin basement membrane disease, though rash will not be there. Secondly, one question comes to my mind is that what do you feel is the single most important factor to, you know, make a patient having a good CAPD for 10, 11 years? What in your knowledge or in your practice you would say is a single most important factor to sustain a patient on peritoneal dialysis for 11 years?
Sir, yes, sir, it is residual renal function. Which is most
I
important.
think most important would be nutrition,
Yeah.
because if these patients, you know, they eat a lot of protein
Yes.
and they have good nutrition, then only they can survive. Most of the patients we see is that after 1 or 2 years, they start having infection, they get malnourished because they are losing protein in the peritoneal fluid
Yes.
and their diet is not keeping up.
Yeah.
So if you see the long drawn, yeah, residual renal function is very important, I agree. But nutrition, what I feel is the single most important. If we tell the patients who are on CAPD, their diet should be double of what a normal person is, especially proteins.
Yes.
And that can only save them. Okay. So that was one point I wanted to tell.
Yeah.
I think that's all, sir. Then we can conclude.
Yeah. One other emphasis should be if a person is disciplined and is doing self-care, that also goes a very long way in preserving a CAPD. I have a 94-year-old general officer, you know, a general from the Indian Army, who was started on CAPD at the age of 76. He's 94 today. And even at this age, he comes walking into my OPD and he does his CAPD himself. His good wife is with him. She is about 89 now, but she says, no, as regards my CAPD, I do not allow anybody else to touch it. So that also helps a considerable amount, because your bacteria on the skin and elsewhere in the gut and everywhere else, you know, your gut microbiome, it's all yours. The moment somebody else touches it, a caregiver, you could get into problems. So this also needs to be remembered. Yeah. And all, of course, dialysis units and nephro units should have a good nutritionist on board. It helps a great deal. I agree totally. Thank you.
Thank you, sir.
Thank you.
Thank you, faculties.